Good afternoon, good evening, or good morning, depending on when and from where you're joining us. I'm Dr. John Iskander, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for May 2018, Be Antibiotics Aware, Smart Use, Best Care. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. And we're pleased to announce CDC's new continuing education website at cdc.gov/getce. Please see the Public Health Grand Rounds website for more details. Our required continuing education disclosure for this Public Health Grand Rounds session is described here. Grand Rounds is available on all your favorite web and social media sites. Please send questions to grandrounds@cdc.gov, and we'll try to include your question during our Q&A part of today's session. Want to know more? We have a featured video segment on YouTube and on our website called Beyond the Data, which is posted after the session. This month's segment features my interview with Dr. Fleming Dutra. We've also partnered with CDC Public Health Library to feature scientific articles about antibiotic stewardship. The full listing is at cdc.gov/scienceclips. In addition to today's outstanding presentations by Dr. Fleming Dutra, Dr. Linder, and Dr. Hun, I'd also like to acknowledge the important contributions of the individuals listed here. Thank you. Please mark your calendars for U.S. Antibiotic Awareness Week, November 12th through 18th. I'd now like to introduce CDC's Deputy Director, Dr. Ann Schuckett, for some introductory remarks.
Well, thanks so much, and welcome everybody. Today we're in for a really great treat in terms of the Public Health Grand Rounds. I've had a chance to review what you're going to see, and it should be thought-provoking and really actionable, I think, no matter where you work or what you're working on. I have to say, as I was reflecting on the content of today's Grand Rounds, I became quite nostalgic, thinking back to more than 2 decades ago when I worked in a group that was launching Get Smart, Know When Antibiotics Work, our attempt to tackle the rising rates of drug resistance in the most common respiratory bacteria, pneumococcus, and this very large problem that we were seeing. I get nostalgic because we have come so far in pediatric antibiotic use, where pediatricians and parents really started to change how they approached the question of taking an antibiotic. We were greatly helped by extremely effective vaccines that have really changed the face of pneumococcal infections in young children. But we continue to have challenges in antibiotic use particularly in adults and in the healthcare sector. I mean, you're going to hear a lot more about that and why we talk about nightmare bacteria and why we all really need a wake-up call in terms of how to address them. The other thing I was reflecting on in reviewing today's Grand Rounds is how similar some of these issues are with the opioid epidemic. You can look at a map of hotspots of antibiotic use, and it looks quite similar to hotspots for opioid use right now, and we're seeing the consequences of these licensed legal medications having unintended consequences. There's a lot of lessons learned from the antibiotic experience that can help us in the opioid war and vice versa. We see huge provider variation, and we have guidelines for both areas. But what we will hear today in some of the remarks is how having a guideline and knowing what you're supposed to do is really not the same thing as doing what you're supposed to do. So I think we're going to hear some interesting remarks about how to change behavior without it all being about knowledge and education. I think another area that has in common between the antibiotic resistance and stewardship challenges and the opioid era is this multi-sector challenge, that it's not just a healthcare situation. We really need to be working across sectors. One of the best ways to work across sectors is with partnerships, and part of our panel today represents the foundation partner as a critical catalyst for change and to really convene and move the field forward. The last comment I want to make is to keep your eyes out for the remarks about behavioral economics and behavioral change for insights that may be useful not just for changing practice, but in your day job. I have to say, after I saw your slides, I started realizing maybe we should move the time of grand rounds from 1 o'clock to another time of day. But sneak preview. Anyway, I think this will be a really stimulating grand rounds, and let's get on with the show. Thanks.
Thank you very much, Dr. Shaukat. Our first speaker is Dr. Fleming Dutra.
Good afternoon. I want to remind everyone of the life-saving benefits of antibiotics. Infectious bacterial diseases that were once deadly are now treatable. And in the roughly 80 years since penicillin was widely introduced, antibiotics have saved millions of lives. Antibiotics are important adjuncts to modern medical advances. They allow us to perform surgeries, transplants, and cancer chemotherapies by helping us prevent and treat bacterial infections in vulnerable patients. Effective antibiotics underpin our ability to practice modern medicine as we know it. And that is why antibiotic resistance is such an important public health problem. CDC estimates that 2 million illnesses and 23,000 deaths in the US are caused by antibiotic-resistant infections each year. Antibiotic-resistant infections can affect anyone, and patients with chronic diseases, such as cancer or complications from diabetes, are at even higher risk. Antibiotic-resistant infections are costly, leading to an estimated $20 billion in excess direct healthcare costs and $35 billion in lost productivity annually. And for those who survive, these infections can lead to significant morbidity. Antibiotic use is a major driver of antibiotic resistance. To illustrate this, let's walk through this brief history of antibiotics. At the top, you can see the year that each of these antibiotics were introduced into the market. And on the bottom, the date bacterial resistance was first identified in corresponding species. And you can see that resistance is never far behind introduction. Note that for penicillin, resistance was first identified after discovery, but a few years prior to market introduction. And while new antibiotics are urgently needed, resistance will likely follow. And this is why we must use antibiotics appropriately. Antibiotics can also cause adverse events. Antibiotic-associated adverse events range from minor side effects to severe reactions, such as life-threatening allergic reactions. CDC estimates that every year, 200,000 emergency visits occur in the US from antibiotic-associated adverse events. And evidence of long-term consequences of antibiotic use is emerging. Antibiotic use has been associated with increased risk of allergic, autoimmune, and infectious diseases, likely mediated through the disruption of the normal microbiome, which is the community of microorganisms that live in and on our body. Clostridium difficile infection is a serious consequence of antibiotic use that disrupts the normal microbiome that protects us. CDC estimates that C. difficile causes 453,000 infections and 15,000 deaths in the United States annually. C. difficile infections occur both in hospitalized patients and outpatients after antibiotic use. These infections can become recurrent and are costly and potentially fatal consequences of antibiotic use. And thus, prevention of C. difficile infection is key. Using antibiotics only when needed, and when needed, using them correctly, is one of our most important prevention strategies. And that is what antibiotic stewardship aims to do. Antibiotic stewardship is the effort to measure antibiotic prescribing, to improve prescribing so that antibiotics are only prescribed and used when needed, to ensure prompt initiation of antibiotics when needed, such as for patients with suspected sepsis, and to ensure that the right drug, dose, and duration are selected when an antibiotic is needed. Antibiotic stewardship is fundamentally about patient safety and delivering high-quality health care. CDC has released the core elements of antibiotic stewardship, which provide a framework for implementing stewardship across the spectrum of healthcare. These include core elements of antibiotic stewardship for hospitals, nursing homes, outpatient facilities, and in 2017, the implementation of antibiotic stewardship core elements at small and critical access hospitals. Partner organizations, such as the Centers for Medicare and Medicaid Services and the Joint Commission, have incorporated these core elements into their programs, requirements, and accreditation standards, which has helped drive the uptake of the core elements. Antibiotic stewardship has been traditionally focused in hospitals, so why should we focus on improving outpatient antibiotic prescribing? This graph shows a total of $56 billion in antibiotic expenditures from 2010 to 15 for humans in the United States by healthcare setting. And of that, $33.2 billion occurred in the outpatient setting, which is more than hospitals, long-term care, and federal facilities. Because most antibiotics used in the inpatient setting are more expensive than those used in the outpatient setting, the actual volume of antibiotic use in the outpatient setting is likely higher. Based on published estimates, 85 to 95% of human antibiotic use by volume occurs in the outpatient setting. It's clear that our outpatient stewardship efforts must include the outpatient setting. In 2015, 270 million antibiotic prescriptions were dispensed in U.S. outpatient pharmacies. This map shows state-level outpatient antibiotic prescriptions dispensed per 1,000 population. States with the lowest outpatient antibiotic prescription rates are shown in light yellow, and increasing outpatient rates are shown in darker and redder colors. The highest prescribing state had 1,319 antibiotics prescribed per 1,000 population, which is more than twice the rate of the lowest prescribing state, at 511 per 1,000 population. While the need for antibiotics may vary by state, this degree of difference suggests that some of the variation may be due to unnecessary antibiotic use. In 2015, the National Action Plan for Combating Antibiotic-Resistant Bacteria contained a significant outcome to achieve by 2020. A reduction of inappropriate antibiotic use by 50% in outpatient settings. And the key word here is inappropriate. So the question is, what proportion of outpatient use is inappropriate? And CDC estimates that at least 30% of outpatient antibiotic prescriptions written in 2010 and 11 were unnecessary, meaning that no antibiotic was needed at all. Respiratory infections, such as colds and bronchitis, were major drivers of this unnecessary antibiotic use. And this means that our national goal is to achieve reduction of overall outpatient antibiotic use by 15%, or half of the unnecessary 30% by 2020. And actually, inappropriate antibiotic use is more than just unnecessary use. There's also room to improve antibiotic selection, dosing, and duration to align with recommendations. And we can see this in the antibiotic prescribing patterns for the most common reason that adults receive antibiotics, sinusitis. Many sinusitis cases can get better without antibiotics, and watchful waiting is a recommended treatment strategy. Nonetheless, some patients do need antibiotic treatment, and most should receive the appropriate type of antibiotic. However, among adults with sinusitis who are prescribed antibiotics, only 37% receive recommended first-line antibiotics, meaning amoxicillin with or without clavulanate. 26% of adults receive macrolides, most often azithromycin, which are not recommended at all for the treatment of sinusitis. And 16% of adults receive fluoroquinolones, which carry a high risk of adverse events. And the US FDA issued a boxed warning for fluoroquinolones, stating that due to their disabling side effects, they should only be used when other options are not available. Have we made any progress in reducing inappropriate antibiotic use? This graph shows the national antibiotics dispensed in US outpatient pharmacies per 1,000 population from 2011 to 15. And we've had a small but steady decline in the rate of outpatient antibiotic prescriptions since 2011. In fact, overall, these rates have decreased by 4% during this time. And as a reminder, our national goal is to reduce overall outpatient use by 15% by 2020. However, if we look at the data by age group, you can see that the reductions in antibiotic prescribing have been entirely driven by reductions among children. Outpatient antibiotic prescribing rates to children in orange decreased by 13%, while outpatient antibiotic prescribing rates to adults in blue have been stable during this time. And this signals a need to have antibiotic stewardship efforts targeted at adult patients and clinicians who care for adults. So what lessons can we translate from improving antibiotic use in children to improve antibiotic use in adults? First, vaccines are key antibiotic stewardship tools. An important example is pneumococcal conjugate vaccine, or PCV, which has been recommended for young children since 2000 in the United States. PCV led to decreases in pneumococcal infections, including the most common reason that children receive antibiotics, acute otitis media, meaning fewer antibiotics are needed. PCV also targets antibiotic-resistant strains of pneumococcus, and thus has led to reductions in antibiotic-resistant pneumococcal infections, allowing more narrow-spectrum antibiotics to be used. PCV is now recommended for all adults over 65 years and for younger adults at high risk of pneumococcal infections. Influenza vaccine is recommended annually for everyone over 6 months of age, and vaccines are the first step in preventing disease, improving antibiotic use, and combating antibiotic resistance. Additionally, public health and pediatricians have worked together for many years to improve antibiotic use in children. The American Academy of Pediatrics and the Pediatric Infectious Diseases Society have incorporated antibiotic stewardship principles into their guidelines by recommending treatment strategies such as watchful waiting before deciding whether antibiotics are needed for certain infections, and recommending narrow-spectrum antibiotics as first-line therapies when antibiotics are needed. And CDC has led educational efforts to improve antibiotic use among children since 1995, and continues to do so with materials such as this public service announcement. Be Antibiotics Aware, Smart Use, Best Care is CDC's national effort to improve antibiotic prescribing and use and to fight antibiotic resistance. This effort has increased messaging for adult patients and new efforts aimed at reaching clinicians who care for adults, including our new CDC training on antibiotic stewardship, which is available freely online to physicians, nurses, pharmacists, and other healthcare providers. Additionally, CDC has incorporated antibiotic stewardship messages into other related educational efforts, including Get Ahead of Sepsis. So in summary, improving antibiotic use through antibiotic stewardship is a key strategy to combat antibiotic resistance and improve patient safety. The outpatient setting is a key target as it accounts for the majority of human antibiotic use. At least 30% of outpatient antibiotic prescriptions are unnecessary, and we need to improve antibiotic selection, dosing, and duration to align with guideline recommendations. We have made progress as antibiotic prescribing rates have decreased for children, but not for adults. And we need to improve antibiotic prescribing to adult patients using the lessons learned. Thank you. Our next speaker is Dr. Jeff Lender.
Thank you, Dr. Fleming-Dutra. So I would like to pick up, starting to think about how you might think about implementing antibiotic stewardship interventions. I'm going to start off by mentioning some specific targets for improving antibiotic prescribing, including where antibiotics are prescribed, who's doing the prescribing, and for what conditions antibiotics are being prescribed. And after that, I want to go over some insights from behavioral science, behavioral economics, and social psychology, and in particular go over 4 interventions and findings that colleagues of mine and I have studied or implemented. We need to understand where outpatient antibiotics are being prescribed. Here, from a commercial data source, I'm showing you antibiotic prescribing volume and rates for retail clinics, urgent care centers, emergency departments, and physician offices. The yellow columns show visit volume, and visit volumes here on the left y-axis. Visits to physician offices, 148.5 million visits from these data dwarfs the other sites. The blue columns show the percent, and the percentages are listed here on the right y-axis, show the percent of visits in each of these sites at which antibiotics are prescribed. And so antibiotics were prescribed at 36% of retail clinic visits, 39% for urgent care visits, and much lower in emergency department visits and physician offices. And finally, the green columns show the percent antibiotic prescribing for non-antibiotic appropriate diagnoses like upper respiratory infections and acute bronchitis. The rate was highest in urgent care clinics at 46% and lower in the other settings. So from a percentage standpoint, it makes sense to focus on the urgent care centers that have high rates of antibiotic prescribing and high rates of inappropriate antibiotic prescribing. But from a volume and public health standpoint, we still need to address antibiotic prescribing in physician offices. This slide looks at who is doing the outpatient antibiotic prescribing. And as a specialty, family practice prescribes the most antibiotics with 64 million prescriptions. The other primary care specialties, pediatrics and internal medicine, are in the top 3, but pay attention to who comes next. We've got dentists, and then nurse practitioners and physician assistants, and so on down through emergency medicine and a slew of other medical and surgical specialties, all the way down here to infectious diseases with 1.3 million prescriptions per year. And to be clear, this is only showing the volume of antibiotic prescribing. This doesn't say anything about the rate or appropriateness of antibiotic prescriptions. But looking at this, if you wanted to have the biggest volume impact, you'd focus on primary care, but don't forget about dentistry and nurse practitioners and physician assistants. So let's take a look now and see for what most antibiotics are being prescribed. Leading the specific diagnoses is sinusitis, where there's about 56 prescriptions per 1,000 Americans per year, followed by otitis media, pharyngitis, skin and soft tissue infections, other skin infections, urinary tract infections, and viral URIs. And there are another 13 specific categories before we get all the way to other codes, and these are diagnoses that didn't fit into any more specific of the preceding 20 categories. And so looking at this, I'd make 3 points. First, if you wanted to pick the diagnoses on which you'd make the most impact on antibiotic prescribing for adults, you'd focus on sinusitis and pharyngitis. Second, it's a bit concerning that the other codes here accounts for the largest share as a group, about 89 prescriptions per 1,000 people. And third, the antibiotic prescribing rates for the leftward diagnoses here, like sinusitis and UTIs, is probably too high, but the right antibiotic prescribing rate is not 0. And I focused a lot of work on this category, viral upper respiratory infections and others for which the right antibiotic prescribing rate is 0. And a lot of what I'm going to talk to you in the next few minutes is going to be focusing on this group of non-antibiotic appropriate diagnoses. So those are just 3 domains we might consider as targets for improving antibiotic use. Where are you going to intervene, on whom and for what conditions? And so now that you've decided what you're going to do, now it's time to turn our attention more specifically to how, and to think carefully about what you're hoping to accomplish. Is your specific goal a reduction in percent antibiotic prescribing, an absolute reduction in antibiotic prescribing amount, or something else, and what intervention will you use? And as you think about this, trying to change physician behavior, let me first offer up a cautionary tale. So this first bullet point, limited success of prior interventions, unfortunately sums up about 10 years of the beginning of my career and the work of many others who implemented a whole host of interventions that didn't really decrease inappropriate antibiotic prescribing. And most prescribers already know you're not supposed to prescribe antibiotics for viral illnesses. So what's the problem? And colleagues of mine and I think we've been using an implicit model of physician behavior that's flawed. We've presumed that clinicians are reflective, rational, and deliberate about what they're doing. And if we just provide the right information at the right time, they will do the right thing. And so we've tried any number of interventions to educate prescribers and remind them about appropriate antibiotic prescribing, but that really has not worked. So in contrast, about 10 years ago, I started working with behavioral economists and social psychologists who ascribe to a more behavioral model of decision-making in which people, including prescribers, including doctors who are people too, make decisions in a fast, automatic way and in ways that are heavily influenced by emotion and social factors. And a lot of the behavioral insights we've tried to take advantage of have been popularized in books like Nudge and Thinking Fast and Slow. And just a few of these ideas include predictable cognitive biases, like a bias to action. We much prefer to do something than to not do something. Clinicians work to preserve their self-image and be consistent over time to themselves and to others. And we're all very strongly motivated by social factors, and we care very deeply what other people think about us. So, and indeed, if you think about the factors driving antibiotic prescribing, they're much more immediate and emotionally salient than the factors that deter antibiotic prescribing. So the drivers of antibiotic prescribing include a belief that patients want antibiotics, a perception that it's easier and quicker to prescribe antibiotics, prescribing just out of habit, and clinicians worry about missing an untreated complication following a just-to-be-safe mentality. And all of these things are emotionally laden and present right there in the room when the clinician's there with the patient. And in contrast, the factors that deter antibiotic prescribing include concerns about adverse effects and drug reactions that happen later. Clinicians might recognize a need for antibiotic stewardship and be concerned about antibiotic resistance, but that's sort of out there too. And clinicians might want to decrease unnecessary healthcare spending, but that too is a remote abstraction. And finally, clinicians might want to follow guidelines, but feel the guidelines don't really apply to the patient that's right there in the room with them. So with that in mind, there's 4 insights from behavioral science, behavioral economics, and social psychology that I'm going to go over. And I'm going to go over decision fatigue, pre-commitment, accountable justification, and peer comparison. So to start us off with decision fatigue, we analyzed about 22,000 visits for acute respiratory infections that was made to over 200 clinicians over 16 months, and we superimposed all of those visits on this graph. And on the x-axis, we have hours of the day from 8 a.m. to the 11 a.m. hour, and then the 1 p.m. hour to the 4 p.m. hour. And I'm going to show you the antibiotic prescribing rate here on the y-axis for diagnoses for which antibiotics are sometimes indicated, like sinusitis and pharyngitis, for diagnoses for which antibiotics are never indicated, like nonspecific upper respiratory infections and acute bronchitis, and then the overall antibiotic prescribing rate. And I will pause and let you think about what you think this graph is going to look like. So I just want you to focus in on this middle graph of overall antibiotic prescribing rate. So focusing on that, we found an increase in antibiotic prescribing during the morning hours and a steady increase in antibiotic prescribing rate during the afternoon. And as I labeled it before, this is an example of decision fatigue in which clinicians get gradually worn down and more often prescribe antibiotics and inappropriate antibiotics for acute respiratory infections later in clinical sessions than at the beginning. So one of the another insight I want to tell you about is pre-commitment posters. So one of the strongest predictors of antibiotic prescribing is clinicians' belief that patients want antibiotics, which is an even stronger predictor for antibiotic prescribing than patients' actual desire for antibiotics. So to try to short-circuit this belief, we developed a pre-commitment letter that had language on it about how doctors were committed to appropriately prescribing antibiotics. And it has language here that says, as your doctors, we promise to treat your illness in the best way possible. We're also dedicated to avoid prescribing antibiotics when they're likely to do more harm than good. And importantly, we had doctors put their picture on the letter, we had doctors sign the letter, and we blew this up to poster size and put it up on the wall of the clinic. And the hope was that a few things would happen. So 1, we're getting a commitment from doctors ahead of time. 2, we're educating patients about the doctor's use of antibiotics even before the visit. And 3, probably most importantly, the doctor knows, the patient knows about their commitment to appropriate antibiotic use. And so to evaluate the pre-commitment posters, we conducted a randomized trial of 14 clinicians stratified by high and low prescribers. And as a control, we used the old CDC Get Smart About Antibiotic posters and put those up in the control clinics. And we compared a 48-week baseline prescribing rate to a 12-week intervention period and examined just under 1,000 non-antibiotic appropriate acute respiratory infection visits. And from baseline to the intervention period, there was an adjusted 20% decrease in antibiotic prescribing for the docs who used the personalized pre-commitment poster, so a good effect with a pretty simple intervention. And it's been gratifying to see the commitment posters are now mentioned in the CDC core elements of outpatient antibiotic stewardship, the EU draft guidance for antibiotic stewardship, and have been used in CDC-funded replications in Illinois, New York, and elsewhere. So another intervention we've evaluated is what we call accountable justification, which we embedded in the electronic health record. When prescribing seemingly inappropriate antibiotics for acute respiratory infections, like for acute bronchitis, the clinician is stopped and asked to provide a brief tweet-length justification for that antibiotic prescription that gets entered into the patient's chart. And if the clinician doesn't enter anything into the patient chart, they're informed that a note stating no justification given is going to go in the chart as their justification note. And so with accountable justification, we're providing an electronic health record-based nudge, making the clinician pause to consider the antibiotic prescribing decision, and also using social motivation by making the antibiotic prescribing decision explicit to colleagues. And the last intervention I'll talk about was peer comparison, which was delivered via email. Each month, we sent clinicians who are in the peer comparison group an email that compared their performance to that of their peers. And two facets of effective feedback that we borrowed from behavioral science were, one, feedback should key off of a top-performing group. If you just show people where they are in the bell curve, the mean actually doesn't move. And two, feedback has to have a little bit of an emotional component to it. So for clinicians who are in the top 10% best performers, those with the lowest inappropriate antibiotic prescribing rate, we told them what you see here. You're a top performer, and provided data about how they achieved their top performer status. The other 90% of clinicians got an email that said, you're not a top performer. And you can imagine how well doctors took to receiving this second email. And so here we're trying to change behavior by using social motivation, clinician self-image, and using emotionally laden feedback keyed to a top-performing group. And to evaluate accountable justifications and peer comparison, we did a randomized trial in 47 primary care practices in Boston and Los Angeles. 248 primary care clinicians participated, and as the primary outcome, we looked at the antibiotic prescribing rate, again, for non-antibiotic appropriate diagnoses, non-specific upper respiratory infections, acute bronchitis, and influenza. We ran the interventions for 18 months, but we were very interested in what would happen afterwards. So at the end of the 18-month intervention, without any fanfare, we just went away, and we examined what happened to prescribing in the subsequent 12 months. So here are the results showing on the x-axis an 18-month pre-intervention period, an 18-month intervention period, and the 12-month post-intervention period. And on the y-axis is the antibiotic prescribing rate for non-antibiotic appropriate diagnoses. So first, take a look at what happened in the control group, which is the open circles here. So from just being in this trial, the baseline inappropriate antibiotic prescribing rate drops from about 35% to 24% at the start of the intervention, continues to decrease through the intervention period, and even continued to decrease through the post-intervention period. So in absolute terms, the most effective intervention of this trial was actually just enrolling in the trial. The accountable justification group had an even lower antibiotic prescribing rate by the end of the intervention period, but after the intervention was stopped, there was some backsliding, so that by the end of the post-intervention period, there was no significant difference in antibiotic prescribing between the accountable justification group and the control clinics. So for peer comparison, we saw a significant reduction in, and this is the same control group, a significant reduction in antibiotic prescribing rate through the intervention period. And after we turned the intervention off, there was an uptick in antibiotic prescribing, but not as much as for accountable justification. At the end of the 12-month post-intervention period, the peer comparison practices still had a significantly lower antibiotic prescribing rate than the control practices. So to summarize, I talked a bit about the where, who, and for what outpatient antibiotics are prescribed. And next, I hope I've made the case that doctors and other prescribers are in some way people too. We're just as influenced by seemingly irrational factors as everyone else, and that effective interventions need to do much more than just provide information or education. And then I talked about these 4 insights from behavioral science, including decision fatigue, pre-commitment, accountable justification, and peer comparison. And so I'll stop there and turn things over to Dr. David Hyun from the Pew Charitable Trust. Thank you.
Thank you, Dr. Linder. So we just heard about antibiotic stewardship strategies and interventions that have been effective in reducing inappropriate antibiotic prescribing. Now we're going to discuss how to scale up these stewardship activities and systematically implement them across the various healthcare settings. And already several policies have been established that promote and facilitate uptake of antibiotic stewardship activities, and these policies are set at the national level as well as the state level and are driven by both governmental agencies and non-governmental organizations. So the Pew Charitable Trust is a nonprofit and nonpartisan organization, and I'm part of Pew's Antibiotic Resistance Project, where we address the issue of antibiotic resistance through research and development of policy solutions in 3 areas: antibiotic stewardship in healthcare, which is where my work is, antibiotic stewardship in animal agriculture, and antibiotic innovation. Many of the current antibiotic policies focus on hospital settings as there has been more evidence and consensus built on the effectiveness and the need for antibiotic stewardship programs in these settings. And in contrast, developing stewardship policies for outpatient settings has proven to be more challenging, as there has been relatively less research and experience in establishing effective and feasible ambulatory strategies. In 2006, California became the first state to require acute care hospitals to implement antibiotic stewardship programs. The language in the first bill reflects the concept of antibiotic stewardship during a time when hospital antibiotic stewardship programs were not yet widespread. So the broad definition of this particular requirement presented challenges in interpretation and enforcement. And in 2014, another state bill was passed that provided more specificity, requiring stewardship programs to be in accordance with federal or professional society guidelines, be multidisciplinary, and include appropriately trained personnel. As a result of the legislative requirements for stewardship programs, the California Department of Public Health has taken roles in both assessing compliance through facility licensing surveys, as well as providing support and guidance for hospitals in implementing stewardship programs. CDPH's California Antimicrobial Stewardship Initiative provides antibiotic stewardship toolkits and leads collaborative projects with hospitals that provide guidance on implementing stewardship activities. In 2016, Missouri became the second state to require that hospitals implement antibiotic stewardship programs. And similar to the first California state bill, the stewardship program requirement was added to a bill that addressed healthcare-associated infections. Missouri's bill is notable in that it specifically calls out the stewardship of last resort antibiotics as a priority for the state's hospital antibiotic stewardship programs. Also noteworthy is that the state bill requires hospitals to report antibiotic use and antibiotic use measurements and antibiotic resistance data to CDC's National Healthcare Safety Network. This is the first state to do so. The National Healthcare Safety Network, or NHSN, is widely used to track healthcare-associated infections, as well as antibiotic use and resistance. And it can serve as a valuable tool for hospital antibiotic stewardship programs to not only monitor their facilities' antibiotic use and resistance over time, but also compare their data to other similar hospitals. Beginning in January 2017, the Joint Commission, which accredits 77% of U.S. hospitals, implemented a new standard for antibiotic stewardship as part of their accreditation surveys. So the standard requires hospitals to develop and implement stewardship programs with specific organizational, structural, and process elements. These elements align well with the CDC's core elements for hospital antibiotic stewardship programs, with an emphasis in creating accountability of the stewardship program's performance, tracking and reporting activities and outcomes, and using a multidisciplinary approach. The Joint Commission Antibiotic Stewardship Standard is evolving, and in recent updates provided at conferences and at the Presidential Advisory Council for Combating Antibiotic-Resistant Bacteria, the organization indicated that they are prospectively monitoring survey results specific to the stewardship standard and are collecting feedback from surveyors and hospitals on the feasibility and logistics of applying the standard in the accreditation surveys. These data will help adjust and refine the standard and the survey methods employed to appropriately assess the quality of antibiotic stewardship programs. Due in part to these policies requiring antibiotic stewardship programs in hospitals, over the past few years, we have seen a noticeable increase in the number of hospitals that have implemented stewardship programs. The annual survey of acute care facilities that participate in NHSN includes questions to assess whether hospitals had stewardship programs in place and to determine how much of the CDC core elements are incorporated into those programs. Between 2014 and 2016, the percentage of hospitals in the U.S. with antibiotic stewardship programs that included all 7 core elements rose from 41% to 64%. When you look at this data state by state, there are significant variations. And since we discussed California and Missouri's state legislation addressing hospital antibiotic stewardship, here are numbers specific to those 2 states. In California, the percentage of hospitals with antibiotic stewardship programs that fully meet CDC's core elements has been consistently much higher than the national average. When you look at Missouri, we see a significant increase in 2016 in the percentage of hospitals with stewardship programs meeting the core elements. The same year, the state legislation was passed requiring stewardship programs. So I want to highlight the value of these core elements and their related guidance documents when it comes to policymaking, primarily drawing from the experiences of hospital antibiotic stewardship policies. First, the core elements provide a baseline consensus among various stakeholders about the general principles of antibiotic stewardship. It also helps maintain consistency across policies on some of the specific components, which in turn reduces the likelihood of any additional or contradictory requirements or regulatory burden for the institution and providers when multiple policies are implemented by different entities. Now, this slide lists the core elements for hospital antibiotic stewardship and for outpatient antibiotic stewardship. And the core elements are designed to outline key principles and strategies of antibiotic stewardship, but leave sufficient flexibility for facilities and providers to meet the core elements. And the guidance documents provide specific examples of stewardship actions and interventions, but avoids being too prescriptive. And these characteristics allow the core elements to serve as efficient guideposts for policy making. The core elements are also tailored to the specific healthcare setting, as demonstrated by the differences in hospital and outpatient elements. And these differences also present challenges in translating the success of antibiotic stewardship in hospital settings to outpatient settings. So, what are the differences that make outpatient antibiotic stewardship more challenging? In hospitals, a centralized organizational structure provides incentives to providers to promote uptake in antibiotic stewardship. So hospitals can leverage their internal policy making to make their providers participate in their stewardship programs. However, in the outpatient space, incentives to providers are fragmented across multiple organizations, for example, private and public payers, as well as regulatory entities such as health departments. Hospitals also have more centralized resources that can help meet the operational needs of antibiotic stewardship activities, and this is evident when it comes to measuring and tracking antibiotic prescribing, where many hospitals can take advantage of electronic data infrastructure and IT support, as well as data analytic capacities. These resources are not typically available in many outpatient practices and present a major hurdle for antibiotic stewardship. And finally, many hospitals employ personnel with infectious diseases and quality improvement expertise needed to develop and design antibiotic stewardship activities tailored to address problematic prescribing patterns. And these types of technical expertise and assistance will need to be provided for outpatient practices. Many of the stakeholders are actively engaged in some specific outpatient stewardship activities. Aetna recently sent letters signed by its chief medical officers to 1,115 clinicians who prescribed antibiotics to at least 50% of their patients with acute bronchitis, reminding them of the guidance on the management of acute bronchitis, where antibiotics are not recommended. And the prescribing rates were analyzed from claims data and included internal medicine and family practice physicians, physician assistants, and nurse practitioners. This measure of antibiotic prescribing rate is an existing quality measure that developed and utilized by the National Committee for Quality Assurance as part of its Healthcare Effectiveness Data and Information Set, also known as HEDIS. The American Academy of Pediatrics recently shared the results of their quality improvement project, piloted among 6 pediatric practices in Virginia. And the QI project focused on avoiding antibiotics for viral upper respiratory tract infections, improving antibiotic use for otitis media, and educating patients, parents, and families on appropriate antibiotic use. This was a collaboration with CDC and a health plan company that provided incentives for providers to participate by giving them rewards through its quality scorecard program. And the project demonstrated increases in the rates of use of recommended antibiotics for otitis media and a slight decrease in patients who received an antibiotic for viral URIs. There are also outpatient antibiotic stewardship activities led by state health departments. In 2015, the Illinois Department of Public Health developed their Precious Drugs and Scary Bugs campaign to improve antibiotic prescribing with a focus on acute respiratory conditions and enrolled 38 practices. So providers were asked to display commitment posters and participated in education webinars. Utah Department of Health recently publicly shared antibiotic prescribing rates for acute bronchitis by clinics in their state on their Open Data Catalog website, and this HEDIS measure was analyzed from the state's All Payers and Claims database. And the last example I want to highlight is that the Centers for Medicare and Medicaid Services tasked the Quality Improvement Network and Quality Improvement Organizations known as QIOs to implement the CDC's core elements of outpatient antibiotic stewardship in recruited facilities that manage Medicare beneficiaries. The QIOs work regionally to help disseminate best practices that improve clinical quality and patient safety and have recruited over 7,600 physician practices, emergency departments, and urgent care facilities. So most of these examples touch on measuring antibiotic use and providing technical stewardship expertise, but most do not directly create incentives for provider participation. And the next challenge will be developing comprehensive policy strategies that also addresses incentives. And we'll also need to continue to assess gaps at the practice level, such as the capacity to measure antibiotic use or provide relevant expertise to apply stewardship interventions. It will also be important to identify other public health stakeholders best positioned to fill any of these resource gaps, in addition to the public and private payers and state and local health departments. And one more reminder to mark your calendars for U.S. Antibiotic Awareness Week on November 12th and 18th this year. Thank you very much.
And with that, we'll be happy to take questions. And I'll take the first question from Susan, if there's any from the remote audience.
Thank you. And I want to remind our online audiences to send your questions to grandrounds@cdc.gov. From Alicia, more than social motivation, what about making bad decisions harder to make and good ones easier? For example, needing to scroll to find the order for the antibiotic when the diagnosis is not appropriate.
So I actually glossed over one of the arms of the trial I told you about. So I told you about working backwards, peer comparison, accountable justification, and a third arm in that trial was called suggested alternatives, where we did just that. So if somebody went to prescribe an antibiotic for a non-antibiotic appropriate diagnosis, we easily offered up a list of over-the-counter things with the prescriptions all teed up for the doctor. You could just click and check. And if you still wanted to prescribe an antibiotic, way down at the bottom of the screen in tiny little font, there was a little checkbox that said you could still prescribe an antibiotic. Turned out that one actually didn't work. And in another study we did, doctors anticipated that would be the most effective intervention before we ran the intervention. So doctors were wrong about what was going to work. And unfortunately, and that was the one that most looks like traditional clinical decision support, and it unfortunately did not work.
We're happy to take questions from the audience as well. You can either line up at one of the mics or use the mic on your front. Yes.
So thank you. This is, I'm Vaughn Nguyen. Thank you for a great presentation. This is a question for Dr. Hyun. So you showed a graphic where looking at hospitals versus outpatient centers and showing that the rates of antibiotic prescribing were different in those centers. But simultaneously, there are many outpatient clinics that are now being bought up by hospitals, so they're actually becoming part of larger systems. And this actually applies to urgent care centers as well. They're sort of being bought by hospital systems. Do you see any differences from independent outpatient clinics versus those that are part of a larger corporate entity, whether it be urgent care or primary care out in that setting?
Yeah, no, that's absolutely true, we think. And we're actually doing some research right now to better delineate the sort of the resource capacity differences in the average outpatient clinic, and that goes to your point, what is an average outpatient clinic these days? And so our preliminary work, we've done some focus groups as well on this, and trying to understand how the outpatient clinics and practices are prepared, or whether they have the right resources to do the stewardship. And certainly facilities that are affiliated with healthcare systems, especially if they're sitting directly in the hospital-based campus, hospital-based campuses, will have more direct access to not only the data infrastructure, but also there's a culture of quality improvement that it's been more widespread, I guess, and more they've been more exposed to it if they've been part of a hospital system. And of course, they have direct access to infectious disease doctors. It's easier to pick up the phone and talk to them when they're in the same building. So there most likely is going to be some differences in those type of resource availabilities and expertise access. I think the question really is going to become, how do we address all of those? And we probably need to focus more on the outpatient settings that are going to have relatively less resources to work with, because we believe that's where the bigger challenge is going to be.
And one thing, I would just add to that the AAP, the American Academy of Pediatrics collaborative that David mentioned, actually enrolled private practice, primary care practices that were not affiliated with larger systems. So that's one potential model of using health professional societies to reach those types of providers. Yes, ma'am.
Yeah, thanks again for terrific presentations. In the old days, one of the challenges was, that you do an intensive, expensive intervention, and then there was the question of persistence, or whether you had to redose or boost to get the effect. So I was intrigued about, just enrolling in the trial. You had quite a bit of impact. I wonder whether whether any of you want to speculate on what's the best way for us to have persistent or long-term change, knowing that everything can't be a trial, and that what you've gained from the behavioral research.
I'd go back to the control group in the trial, right? Just enrolling in the trial, knowing you're being watched. And there was something else, and this is the reason why you do randomized controlled trials, is because clearly something was going on among those who were enrolled in the trial, even though they were not the target of any specific intervention we were doing, other than them knowing that we were watching them. So that's an inexpensive intervention. Of course, I work with psychologists who think, then we should do the experiment about telling people we're watching them, but not actually watching them. It gets diabolical pretty quickly. So I think some degree of monitoring, but there's got to be fatigue in just being monitored over time, and think about all the domains in which we could be evaluated in terms of peer comparison. It's endless, and so this has to be scalable, keep people's attention, and I think we just need a culture shift around this too. And hopefully that's what we were also seeing in the control group, was a culture shift.
Yes.
From Diana and our online audiences, why isn't rapid diagnostics a requirement in hospitals and communities? Why do we wait 3 days before having information to tailor drug therapy?
I'll start, and then I'll...
Catherine knows what I'm going to say. Go ahead.
I might say the same thing. I think, in the outpatient setting, there are a couple of conditions that are commonly lead to antibiotics for which there are good rapid diagnostics. So, for example, streptococcal pharyngitis. There is a good test, the rapid strep test, that can determine whether someone has streptococcus in their oropharynx. Now, there are some challenges even with that good test, and that you have to appropriately select the patients to be tested. If you test everyone, you'll pick up colonization, which is not infection, and that will also lead to inappropriate antibiotic use. So there's some examples, but there's currently other common infections such as otitis media or sinusitis where there is no good test that will tell you whether the patient has it. There's a set of clinical criteria or examination criteria that have to be used. And so right now we're just not there for most of the common infections for which antibiotics are prescribed in the outpatient setting.
And I would take a little bit harder line and say, the guidelines tell us when to prescribe antibiotics and when not to, and they are right most of the time. We can follow up with patients, and so if I'm evaluating a patient in clinic, I don't need any additional diagnostic information. I think it's only going to confuse things, and the idea that we're going to have like that perfect test that's going to attach to your iPhone that you have somebody sneeze on, and it's going to have perfect sensitivity and specificity to give us more information than we have now, just strikes me as highly, highly unlikely.
And I'll just add, I think there's also more evidence on the inpatient side of the experience of using diagnostic tools. And a lot of the studies are pointing to that just having the mere presence of rapid or diagnostics or molecular diagnostics is not sufficient enough to change antibiotic prescribing behavior, that most of the successful implementation were paired up with a very active antibiotic stewardship program that actually provided guidance to the provider on how to act on the result of the results. So I think that's probably most likely to be very true. It's even more so true on the outpatient setting, especially given the examples that Catherine mentioned about group A the misutilization and misinterpretation, or the ignoring the group A strep result and still prescribing antibiotics.
Do you have additional questions from the remote audience?
Yes, we do. From our Grand Rounds email box. What is considered prescribing too much or too little for infections such as gonococcal infections in terms of same-day treatment before receiving a lab result?
So for specific infections, we encourage healthcare providers to look to the National Clinical Practice Guidelines for those. And CDC, I believe, is the one who actually puts out the STD treatment, diagnosis and treatment guidelines. For other common outpatient infections, it's health professional societies that do that. But so I would refer that question to the STD treatment guidelines.
We have more.
And no more. If anyone has a question in the audience, please raise your hand. Otherwise, we'll take a remote.
Jonathan says from Facebook, Dr. Fleming Dutra mentioned the FDA warning on quinolone damage, which can be severe and permanent. This info has been very hard to communicate effectively to prescriber community. Any indication this is improving or ideas on how to improve it? The uptake is currently slow.
Yes, and we, as part of CDC's activities, we do monitor, as I showed you some of the data, outpatient antibiotic prescribing rates as well as by class, and we'll be looking as we get newer data at fluoroquinolone rates in the coming years after the box warning was released. But certainly it is important that we are communicating to providers about adverse events, and it's also very important for providers to communicate that information to patients, and they we can help, and part of our mission or what we're trying to do with Be Antibiotics Aware is to have increased messaging about the harms of the potential harms for antibiotics, so that patients and providers think carefully about when they're needed and when they're not. Yes, Ben.
And that brings up a question. I'm Ben Park from DHQP. I'm interested to know more about consumer marketing or education. What works and what doesn't, and what do the data show?
That is a great question. Jeff looks like he has an answer. So.
Well, I think we're just going to wind up throwing it all the way down the table. But that is a great question because I would say, as soon as any of you who've done stewardship, the first thing you hear from doctors is it's the patients. Like the patients are demanding these, and so please, CDC, educate everyone, and you have been, and it hasn't, it's moved the needle a little bit, but kind of not enough. There have been other national programs that have shown effectiveness in reducing antibiotic prescribing rates, particularly a few countries in Europe. But your question, what works, what doesn't? I think there's some data that multifaceted interventions work better than simple targeted things. And then I am going to kick it over to David.
So my answer would be that we actually don't do what's called campaign results, but I can still comment on it because most of our work is tends to be provider facing and the healthcare system delivery. But I think there, I agree with everything that Jeff said. I think there is definitely a need for patient education and consumer education, so to speak. And there's examples from the animal. I think one of the direct examples that I've observed from my work at Pew has been, the influence of consumer opinion and demand, so to speak, on the animal agriculture side, where over the last several years there's been, increasing consumer demand for antibiotics-free, quote-unquote, antibiotics-free products, and that's definitely helped move the needle past that. I think, and it's absolutely true, when you talk to providers, they feel a tremendous amount of patient pressure and patient demand, and that needs to be part of the equation of when we're talking about stewardship, how we're going to potentially alleviate that for the provider or neutralize it, whether it's through communication, training them through certain communication techniques, and driving the discussion in a way that they'll get to a place where both the provider and patient can agree not to use the antibiotics.
I would just add to that it is quite difficult, as Jeff said, to measure the impact of large national educational efforts. But as we've seen antibiotic prescribing rates decrease to children, we've also seen that parents tend to be more savvy about antibiotic resistance and appropriate antibiotic use. They're more concerned about adverse events for their children around or antibiotics in particular than necessarily adults are for when they take antibiotics for themselves. So even though it's difficult to show that a large national campaign has impact, I think that the fact that CDC has been focused on improving antibiotic use in children for so many years, many of the early campaigns were focused solely on children, we think that we're starting to see some of the fruits of that labor.
And I would actually take the opportunity to take your question and flip it back on the healthcare system. We do a terrible job of taking care of people remotely. You could make an argument that for sinusitis, maybe for pharyngitis, people should come in colds, other things like we don't need to see people in the office. But people have taken time off to come and see us, which turns a visit that should never have happened in the first place into this incredibly fraught conversation that the patient thinks like this is my only chance to get antibiotics, and the doctor's worried that the patient's only there to get antibiotics. And so I think we need to do a better job of setting the system up to do better triage and even pre-visit education.
Yes.
From our Grand Rounds email box, from Francis. Wondering if some consideration is being given to including diagnosis, especially for antibiotics, on prescriptions, being submitted to pharmacies to be filled by pharmacists. This will help the pharmacist effectively serve as another level, another eye, favoring guideline-focused prescribing.
I mean, I would just say yes. I mean, I have a colleague from Brigham and Women's Hospital who one of his main thrusts of his work is indication-based prescribing, which, as you say that, it's like, why don't we do that? It's another regulatory hurdle demanding that physicians prescribe a rationale for every prescription that goes to the pharmacy. So it doesn't seem like it would be that hard. But then I think if you take that one step further, do pharmacists really want to be in the position to say, oh, I'm sorry, your doctor prescribed this antibiotic for a non-antibiotic appropriate diagnosis. You're going to have to go get a better diagnosis from your doctor. So it doesn't quite, it kicks the can down the road, but I'm not quite sure it solves the problem.
All right. I'd like to ask for another round of applause for our speakers. Thank you all very much for joining us for Public Health Grand Rounds. Please join us again for our next session. Thank you.